Hello, everybody.
Hello, everyone.
Hello, everyone. It is January 11th, 2021. Welcome to the 11th. It's the golden 11th day, January 11th, our 11th Facebook Live, talking about COVID-19. Joining me once again is my friend, colleague, and medical partner, Clay Ackerly, here to answer all of your questions about COVID-19. Clay, thanks again for joining me.
Absolutely. Thank you for having me. It's great to be here.
So much fun. We have so much to talk about. I mean, at least in DC and the DMV area, we've had a pretty big rollout of vaccines starting today for patients in category 1, people who are over 65, in the DC area, people who are over 75 in Virginia. So it's a pretty exciting day, yet lots of questions are floating around about, you know, should we get 1 dose to more people versus 2 doses to fewer people? What about these mutant viruses? Should we do things differently? Do we need to mask up differently? So tell me what your thoughts are, Clay, about like, what are you hearing the most from patients, and like what are like the top concerns you're hearing in your patient population right this minute?
The only concern right now is vaccine. How do I get it? When can I get it? Where can I get it? Certainly the other things you raised are all really, really important, and certainly the national policy and local policies on how to distribute matter a great deal. It's easy to now lob a lot of criticisms from all over the place. I just feel very fortunate now that even and my patients know I've criticized it for a while, but the vaccine is now flowing to non-healthcare workers and those not in nursing homes. And that's a great relief to me, and I know it's a relief to many of my patients, only a fraction of whom have been able to get an appointment to get the vaccine, but it has started. So that is a really good moment, I think, now that we've moved to the general population, meaning non-healthcare workers, not those living in a nursing home, so high risk or older adults. But it's a big day here in DC in particular, now that has started.
Yeah, I mean, I'm getting lots of questions today in particular that you may be getting as well. You know, should I get the vaccine if I have allergies to pollen, allergies to peanuts? I had a rash once after I got the Pneumovax. I had a sore arm and I felt crappy for a day after the Shingrix. And I'm reminding people what the science is, which is that, you know, the vaccine has been shown to be safe for everybody unless you've had anaphylaxis to a vaccine in the past. And even patients who've had anaphylaxis to a vaccine or a component of the vaccine in the past still can get it. They just need to be closely monitored. So, you know, if you've had itchies after being around a cat, like, still get the vaccine. It's completely safe.
Yeah, I mean, anaphylaxis, all the anaphylaxis episodes, I think people have done well, right? And it's 1 in 100,000 risk. And I think we're identifying the ingredients in there that are causing the problem. So just get the vaccine.
Just get the vaccine.
Yeah. And I think the vast majority of the, 98% of any reactions are within the first 2 hours. Typically, you'll have time to take your Benadryl. If you do have a history of anaphylaxis to other things, sure, make sure that the expiration date on your EpiPen, right, is up to date. Get your vaccine.
Yep. And so let's talk about, I mean, there's so many things to talk about, Clay, and you tell me where you want to start and people can start firing with questions. You know, one of the things I'm getting asked now, particularly as patients over 65 are getting vaccinated or getting in the queue, is, you know, once I'm vaccinated, can I see my grandchildren without worry? You know, it's a wonderful thing to think about these older patients that we have, and my parents, for example, getting vaccinated so they can not live in quite as much fear about getting COVID-19. But there are still asterisks here. It doesn't mean when you are vaccinated after having had 2 doses that you can all of a sudden let down your guard entirely, because the fact of the matter is the vaccine, 2 doses of the vaccine, has shown to protect people from getting COVID-19, 95% protection. But there's still a 5% chance you could get it. There's like a very low chance that you would get very, very sick from it. In fact, I think the data is like 0. It's 100% effective at severe disease. But what the question of the day is, and we won't know the answer to this question for many, many months, is do vaccinated people, are they sterilized from the virus? Are they not able to carry the virus in their nose and then transmit it to other people? But I do think, once you have, grandparents vaccinated, we can feel pretty darn good that they are not going to get COVID-19 themselves.
Yep. I agree. I think I know we talked a little bit about it last time, and there's more data coming out about the variants and the mutants. And I'm really glad that we now have the capabilities of doing mass sequencing to track this and understand it. And there is that chance, right? It's not yet. And Pfizer came out recently saying that the variants that are known today, the vaccine still works for those based on in vitro studies, right? So in the lab, it seems to work. So that's really reassuring. And I think the efficacy data to date shows when you get vaccinated, 7 days after your second dose, the likelihood of you getting severe disease is minuscule.
Yep.
That's amazing, right?
It
so
is
as we
amazing.
talk about how dark the winter has been, how dark things are, the fact that we can say that,
it's
that
pretty
getting vaccinated brings your risk of really getting sick to nearly zero is amazing.
It's amazing.
And we have to, just say, thank you for that, and hopefully keep our guard up. We don't know when a new variant might pop up. If you are high risk, still be careful. You could potentially spread it to others. So yeah, mask wearing makes sense, but for the things that matter to you, the things that are going to improve your mental health, the things, that first travel that you've been thinking about, a couple weeks after your second dose, it makes sense to begin to start planning in that way.
Yep.
I think it's totally fair.
Totally. So I think we're getting a lot of questions in already, which is great.
Right.
Remember last time we had so many questions that we kind of needed to go rapid fire. So we might as well just dive in.
Okay.
Someone just asked the question that I hope we just answered, does the vaccine prevent you from carrying COVID? We don't know. And the way we're going to know that is we're going to have to watch people, and this is being done right now, studying people who have been vaccinated. And we need to figure out if those people, when you contact trace, people who have COVID-19, does that contact tracing lead back to people who have been vaccinated as identified people who could have potentially transmitted it, even though they themselves didn't get sick and they themselves were vaccinated? So that's going to be a difficult question to answer, but ultimately a very important one. Yep. This is a great question. What is the seemingly quick protocol of treatment that higher ups in the government have received? Well, this is a thing that people get when they test positive right away. So this is what we've been talking about. It's called monoclonal antibodies. One way to fight the virus in the early phases of the virus living in your body, where it's replicating fast, is to treat you with monoclonal antibodies, which are antibodies that are made in the lab that are modeled on the antibodies from real COVID survivors who have made antibodies themselves. This is much more widely available than it was even a couple of weeks ago. Dr. Ackerly and I both have patients who we've ordered these for. It's not supposed to be just for higher ups in the government. It's supposed to be for anybody over 65 and people with underlying health conditions. So this is where you need to talk to your primary care doctor. Absolutely. If you have one, and also,
and if you don't have one, you can self-refer.
You can self-refer. That's
in Maryland. In Maryland, you need a doctor's order. Washington Hospital Center, you just call a number. You don't need a doctor's order. ANOVA, it's anova.org/COVID clinic, and you fill out your information and the fact that you have a positive COVID test, and a doctor they'll call you up, set up an appointment to do a quick screening and to get antibody treatment.
It's great.
It's absolutely worth doing, and it has been unfortunate that, like the vaccine, not enough of those doses have been given, but it's not a cost issue. It's an administrative hurdle that is getting easier and easier to meet. So,
and you can also go on the Eli Lilly website and call their 1-800 number to find out what facilities near you might be offering it. So gosh, we're getting a lot of questions. And again, I'm trying to look at them as they come in. So apologies for people who've written in and I'm not looking, I can't see.
Yeah, there's one about pregnancy. I would
Yeah,
certainly
go for
talk
it.
to your,
Why don't you answer the pregnancy one?
about obstetrician. I think, I believe ACOG says that it's okay to get the vaccine. They haven't seen
Yeah.
any data that suggests it's a problem, but it hasn't been studied formally. So
Yes.
I think there's an encouragement, especially if you're a high risk individual, if you're working if you're a nurse in an ICU, that's different than if you're, working from home and you feel like you can, wait it out. But I think they are encouraging people to consider it. I talk to your obstetrician.
If you had COVID-19 yourself, is there urgency to get the vaccine? We have not seen cases of people getting reinfected with coronavirus within the 90 days after the initial infection. So if you're able to wait and give your spot in line to someone else for the first 90 days, at least that's probably okay. But of course, because there are, new variants and because, you can get COVID-19 twice, you should get vaccinated, but you can probably wait 90 days without any problem.
Yeah.
And
The
someone else
CDC is
asked,
recommending the 90 days. Yep.
yeah, and DC's recommending the 90 days. Someone saying, I think there was a mention of getting COVID after the first dose of the vaccine, and should you get the second dose, I think it's important to note that you absolutely can get COVID after the first dose. Remember that we don't achieve full immunity or the 95% immunity to COVID-19 until you have the second dose. So it makes sense that if you're only 50% covered or some such number, you're still at risk. Whether or not you should get the second dose, I mean, that is really, that's just not been studied well enough.
Yeah, I agree.
Certainly getting the natural disease would give you, the antibodies you need, and maybe you could wait on the second dose. But, that's just a clinical judgment call you'd have to make.
Yeah, I agree. I'll wait for CDC guidance on that one.
Yeah.
Do you anticipate this to be something that you need to get yearly, like the flu shot? Potentially.
Great question.
Potentially. I think we need to see. Right? We need to see what these variants do. We need to see how fast we're able to stomp it out. I think a lot of virologists early on were like, this is a virus that doesn't mutate as quickly as the flu does, and that there's a chance that this was not going to be a problem.
Yeah.
Given the amount of virus, the amount of opportunities for it to mutate and get better, it is a concern. That said, it may not be able to mutate enough to make these vaccines ineffective. Could it take it from 95% effective to 75% effective or 60%? Maybe. And we'll see. I do foresee probably in 6 to 9 months, the Pfizer or Moderna coming out with an update, right? If it's clear that the spike protein has evolved, but I don't know. I have a sense that it may be sort of a tweener, right?
Yeah.
Something like a tetanus or something to say, you know what, we probably want to make sure, depending on how much virus is out in the community on an ongoing basis, do you want to get the occasional booster? Is that annual? Is that every other year? Maybe we wait and see with all the surveillance we're doing now with testing.
Yeah.
Okay, it's looking like it's a bad COVID year. Get your COVID shot.
Yep. Yeah, I mean, I think it's important to note, that viruses mutate. That's what they do. It's normal and it's expected. And coronavirus is no exception. It has already mutated, in fact, thousands of times. Viruses naturally, kind of shift their genetic code every now and then, and sometimes they get lucky and they mutate in a way that makes them more able to latch on to their host and survive and replicate and transmit to other hosts. So, it's sort of a matter of time. I would think. I mean, I'm not a virologist, but I do remember this stuff from medical school. That it stands to reason that it would mutate over time. But there are, as you said, like the measles has not mutated at all, such that if you got a vaccine back in the 1960s, you're still covered today.
Yeah.
So it's really interesting. I mean, there's just so much more to learn. But as I was saying to a patient today, the technology of these mRNA vaccines, like the Pfizer and the Moderna vaccines, is so sophisticated that to alter the the code of the vaccine to protect you from a new variant, say in 2 years, 10 years, whatever it is not as complicated. I mean, you wouldn't want me doing it. Like I'm not doing it. But it's not as complicated as sort of like more traditional vaccines. And look at the efficacy we have, as you said, Dr. Ackerly, like 95%. So
it's been proven out, and part of that is the fact that now we've proven out that the mRNA technology works, meaning that lipid nanoparticle can meld with your cell, deliver that mRNA into your cell to make a protein that then your body responds to. That's remarkable. I think part of the efficacy is also the fact that that spike protein is a pretty juicy target.
Yeah.
And there may be other things that don't have as many juicy targets, quote unquote, and therefore future mRNA vaccines may not be quite as effective. But again, it's remarkable that that technology works for everybody. I've gotten lots of questions actually about, oh gosh, if I get vaccinated, can I give it to someone else? That is just one protein amongst many. There is no way that you can give COVID to someone else after vaccination. Now, to your earlier point, you can get your first vaccine, catch COVID, give COVID, but you gave COVID because you caught it from someone else before you were immune.
Yes.
Right. So this window, as people start getting vaccinated until they're immune, is really important to keep safe, stay safe. I know you're tempted to let your guard down. We're all tired. We're all, itching for that vaccine, but just stay safe until you're fully out of that window, and then obviously still take some precautions until we prove we can't catch it and give it on. But there's another question here, but I can't find information about how to get the vaccine. For those in DC, I would say potentially go to foxcellinternists.com. That is our website. We've got general information there. I cannot promise that it is up to date. Go to your local governments, more important. If you live in DC, there's a DC website. If you live in Virginia, there are local county websites. So you do have to do some hunting. We do have some information there. I can't guarantee it's always going to be fully up to date, but we do our best.
Yep. Sibley's supposed to be starting to vaccinate people this week. That's the word on the street. So hang on and get registered.
I see a question about donating. If you had COVID.
Plasma, go for it.
Plasma. I'm not seeing that as much of a priority right now. You can call the Red Cross. I think there's still opportunities to do that. But with monoclonal antibody treatment, that has been shown to be more effective than convalescent plasma. So I'm not sure it's as important. I don't know what you're hearing, Lucy, about that.
I mean, I just was listening to our friend Dan Griffin, Dr. Griffin, on This Week in Virology, and he was talking about a new study that came out showing how, very effective it is in the first week of a new diagnosis of COVID-19. So I think, one of the places that I've found very interesting as a resource is the Survivor Corps. So Survivor Corps is like the largest nonprofit organization that's sprung out of COVID-19, where it's like a patient advocacy group, and they have great resources to where you can go donate plasma. So I think do it if you can. But yeah, I think monoclonal antibodies are sort of the cleaner version of convalescent plasma. It's simply the antibodies. It has none of the clotting factors in that sort of straw colored part of your blood when you spin it down. So
there may be a time when the mutations in the virus make the current monoclonal antibody treatments ineffective, and my sense would be because the convalescent plasma has all these different antibodies that it may be more effective comparatively down the line.
Someone asked this afternoon and is here now asking another question similarly on the topic of treatment of non-hospitalized patients with COVID-19. So EVMS has come up with this protocol, Eastern Virginia Medical School, and it's been kicking around since, springtime.
Yep.
And it's a cocktail of medications that includes ivermectin, azithromycin, and zinc, and vitamin D. And, you and I were talking about this briefly before we went on air about, our roles as physicians and our goals as physicians and our priorities in terms of taking care of patients. The first goal we have is to do no harm. And so EVMS's protocol, just to explain to people who don't know what it is, it's a protocol. It's basically what I would call like a kitchen sink style of treatment where, you're taking a whole lot of drugs that are commonly used for other reasons and kind of throwing them at patients who are mild to moderately ill with COVID-19 to hopefully prevent them from being hospitalized. The problem is that there's no randomized controlled trial to prove that these work individually or in combination, and they can potentially do harm. At the same time, you could argue that when you're in a full-on war like we are now, we don't have the luxury of randomized controlled trials and being very, very clean and scientific. And why not just give people the kitchen sink? Well, the answer is because it can do harm. Yeah. And because we now actually have proven treatments for mild to moderate COVID-19, like the monoclonal antibodies and the convalescent plasma. So yeah. I'd be interested in your thoughts, Dr. Ackerly.
No, absolutely. I just added into the conversation a link to the MERIC protocol or the EVMS protocol.
Oh, great.
So I've got real concern about that strategy, but I understand it. They're not quacks, and I think they're doing their best to look through evidence and try to push things out there. A lot of the elements, particularly for those people who are low risk, just caught COVID, in terms of, yes, vitamin D, if you're vitamin D deficient, do it. Zinc at low doses, okay. They also push higher doses of vitamin C and quercetin. I don't know if I'm pronouncing that right, but those are antioxidants. They can be tough on your stomach. They can actually be tough on your liver sometimes, and you got to be careful, right? So I think vitamin D makes sense. Melatonin is part of that, and there is some innate immune boosting part of melatonin. So low dose melatonin at night makes sense. The thing that gives me most pause right now is the ivermectin push.
Totally, that rub gives me the willies.
So the reason for it is there's data, and I'm now basically taking again from our friend Dr. Griffin, his assessment of the evidence from third world countries, frankly.
Yeah,
and there are
and particularly
ivermectin is an anti-parasitic agent. Yep. And a lot of these patients end up ultimately needing steroids and immunosuppressants as they're fighting COVID. So some of the data that makes them look like they're effective at fighting COVID is actually helping fight the side effects of steroids. So if you are in a third world country and you've got a parasitic infection, you get steroids, you're going to get sick. So you give practically prophylactically ivermectin and then the steroids, then okay, that makes sense.
Yes.
But for the US, on the population with very low levels of parasitic infections, to expect that medicine with side effects to be effective, it just
totally agree. And what I'm finding to be problematic is that while, as you said, these people who are coming up with these protocols at EVMS are not quacks at all, there are people who are taking information like this and then running with it and saying that anybody who gets COVID-19 should take ivermectin automatically. Yeah. Agreed. If you're in a third world country and you are harboring parasitic infections like strongyloides, which we just don't see in the developed world as much, then maybe you should consider ivermectin if you end up needing steroids. But I think at this point, at the risk of beating a dead horse, I would follow the evidence and follow the data, and basically hydration, rest. If you get COVID-19, hydration, rest, Tylenol, Advil, zinc, vitamin D, melatonin if you can't sleep, time, patience, and if you're high risk or over 65, try to get monoclonal antibodies.
Absolutely, and I think I do throw in a little bit on the pepsid side with some of the early evidence that might have some antivirals. It's not panned out, frankly, in randomized controlled trials. But if you're taking the Advil, maybe baby aspirin, having some pepsid to protect your stomach, and that's my own flair. It's part of the protocol. I don't think.
And this is
there's
where
not enough evidence behind it, but I still like to use it.
And this is where, we could wax poetic about this all night. This is where, luckily, I think you and I, Dr. Ackerly, will have a job for many, many years to come, because there is, there's science, and then there's the art of medicine, and there's clinical judgment. And the reason we train for a long time and sit in libraries for years and years and, go dateless and don't drink beer for weekends upon weekends.
You're saying there's a reason for that? Great.
Because we're trying to hone our clinical judgment skills to be able to apply the science to the actual patient in front of us. And, we're never going to be computers. We're never going to be algorithmic, sort of spit out information. And so these are interesting questions. These are great questions. And I'm so glad people are bringing these questions to us.
There's one question here. Oh, sorry, go for it.
When is an old fart at age 59 going to get the vaccine? I think it's a great question. now that people are seeing their older, family members over 75, 65 getting it, when am I going to get it? When are we going to get it? Well, it just depends on the supply chain. And I think, who knows, but I would imagine that by late spring, early summer, hopefully it'll be rolled out to just sort of the average, young, healthy person.
Yeah.
And then as for pediatrics, I read yesterday that I think it's Pfizer is finally finishing up enrollment for their phase 3 clinical trial for teenagers, young adults. And that data should be then able to be presented. And I'm assuming, because I can't see any reason why it wouldn't work in kids like it does in adults. I'm assuming if it goes well, then the FDA would approve it right away and then start rolling it out for adolescents also in the late spring. But that is a guess and a guess.
Yeah, I think my concern is less on efficacy and more on safety.
Yeah.
Given some of the multi-system inflammatory disorders they're seeing in really young kids, could that trigger it in that population? Certainly for teens, makes total sense that it would work. We need to prove it. What's also one of these weird silver linings of how badly the pandemic has been run, and there's this risk we talked about, the fact that there's so much virus out there that the mutations do pose some sort of risk, is the fact that these efficacy trials are getting completed faster because there are more infections. So hopefully we will have some of that data as well.
Yeah.
But they're lower down on the list, right? So even if we prove that they're efficacious for them, we got a whole lot of other people to vaccinate first. So, I do worry a little bit about this policy decision too, that the Biden administration is going to need to wrestle with. There's been some coverage in the news, right, about just getting all the doses out, give everybody the first dose, and then figure it out. That could potentially make it for the 59-year-old, could potentially get in there and grab that dose. This is not an ethics question. I'm not discouraging you from it. I'd say anybody who can get a dose, get a dose. And there is a question about if you had COVID and you've got antibodies, should you get vaccinated? I don't know. It's a tough question. But I think if your number gets called, get it. Don't worry about the others. That is a policy issue. Do not feel guilty about getting that shot in the arm. You're potentially protecting others from getting it. But as people can't get their second doses, what does that then mean in terms of your ability to walk around confident that you're immune? We don't know.
Yeah, I mean, I waffle back and forth on my opinion about the giving one dose to more people versus holding the second dose for fewer people. Of course, if we had all the vaccine in the world, it would be moot. The problem is the relative shortage, and hopefully that will be in part solved by getting more vaccine out there. AstraZeneca, the J&J vaccines, hopefully will be approved not too long from now. But I think I end up erring on the side of sticking with the protocol. I mean, Pfizer and Moderna did an amazing job of showing us 95% efficacy of these vaccines when given the way they were given.
Yeah.
Whether they will work given 3 months apart, 6 months apart, we just don't know. And it would be an awful shame to learn that the efficacy wasn't as good if you waited 2 months or 3 months and all that work was for naught. I don't think that it's going to be all for naught, but I just think there's enough vaccine hesitancy. We need this. It's already been such a win. I think we need to stick with the science. But I can see the debate on the other side. I mean, if you can vaccinate more people and get partial protection for more people, then maybe you decompress some of these ERs and ICUs and
then there's the logical middle ground, which is where I think I come.
Yeah.
I said logical middle ground. It may not be logical.
Logical to you.
I think it's logical. A middle
you.
ground would be you have the systems in place to guarantee those second doses.
Yeah.
Once you give them out, but you just give them out and you just need insight into that supply chain and the next shipment that's coming. Right? And if you know how many shots that you've now given, how many you have to have in reserve, you can then, I think part of the problem was they were holding on to those criteria too tightly. Right? So if you have a lot of vaccine hesitancy, as you were alluding to, in certain areas amongst healthcare workers, for crying out loud, they're sitting with these vaccines and they haven't yet allowed to give those vaccines to the general public. So get those vaccines out there, have a really good data system to track, and know when that next shipment comes in, if you're going to give it to the person who is at day 21 versus that new person on day
Yeah.
one, give it to that person at day 21. But if you're holding things in reserve because you don't know when the next shipment is coming, that's the problem. We got to get more insight into.
Well, and that's where, I mean, administratively, I'm not sure we're capable of any of that. So who knows? I mean, if we were in a socialist country, maybe we'd have, anyway, I won't get into the politics of it, but I think that let's just hope there's more vaccine on the way so that everybody who wants a dose or two can get it.
Yeah.
But I agree with you. There, you can make an argument on both sides. I see it.
All right.
A 12-year-old person is asking a really excellent question. Can we explain the science between the 10-day isolation period? What happens during the 10 days after symptoms present that keeps the virus from being contagious? Well, so, I mean, Clay, maybe you could explain it better than I would, but you know, the reason we pick 10 days is because we don't see people after 10 days infecting other people. So where your contagiousness goes down. So that's based on data. That's based on epidemiological data showing that people at day 11, 12, 13, after having COVID-19, they are no longer infecting other people.
Yep.
Why is that? Because our immune system, our innate immune system, our antibodies and our T cells are able to tamp down the virus in most people. And probably a fair number of people are not contagious after 5 days or 6 days or 7 days, but we err on the side of caution, of course, for obvious reasons, and 10 is where it lands.
Yeah, I think that's the 80-20 rule, but really probably the 98-2 rule in terms of there will be the occasional person for whatever weird immune system they might have that could keep it tamped down, but last beyond that 10 days.
Yes.
But the CDC has been consistent for a long time, and I know they've looked at this hard, which is it's the 10-day rule, but it's you have to be 24 hours after your fever is broken without the use of Tylenol, Advil, and the like, and any other symptoms you have must be improving.
Yeah.
So you can be in day 14, and if you've got persistent fevers, you haven't beaten the virus.
Yeah.
But once you break that fever, it's been that long since your first symptoms, you can count. Even if you've got viral particles in your nose, you don't have enough to get other people sick. And that's that whole frustrating thing of the person who gets the virus first in the household, they're on the 10-day clock. The rest of the house is on the 14-day clock, right? And let's say there's a third person in the house who's done really, really well and not getting it, but the second person in the house gets it, then that 14-day clock starts again, while the rest of the family who got coronavirus first is, free to leave.
Yeah, which is why you're seeing a number of adolescents and young people being like, I might as well just get the damn thing because then I get to be done in 10 days, which is not, of course, the right answer from a public health standpoint, but I understand it, because otherwise you're sort of tagging on these quarantine after quarantine after quarantine. Yeah. So I think someone asked a really good question, just because ultimately, why do we care about all this science? And it's because we want to live our lives. We want to bust out of these shackles and see people again, dine in restaurants, fly on airplanes. I mean, hell, I just want to hug somebody, anybody at this point. So I think it's a really good question when you ask, what about grandparents getting vaccinated? And what about Lena Wen, who I really admire and respect, who put out a piece, I think it was yesterday in the Washington Post, saying that, if grandparents have gotten vaccinated, she would advise for non-vaccinated grandkids to still isolate or quarantine before visiting the grandparents.
I don't get it.
What's that?
I didn't read the article, but I don't get it.
Yeah. Someone wrote in just now to our Facebook Live.
I see the question. I
think it's very conservative. I totally agree, and it sounds like you do too. I think the point of getting the vaccine is to be able to live your life in ways that are meaningful. But as long as you understand that there's a 5% risk, you could still get it, and you can still transmit it to others. You could give it to your grandkids. But yeah, what are your thoughts on that?
I think there's you need to wait 7 days after your second dose before you can be confident. And I think, sure, if you want to play we're trying to avoid those rare cases, then okay, wear a mask. Well, yeah, we're tired. Get your vaccine.
It's going to be very.
And I think, hug your grandkids. Do not worry about it.
That's what I would say. I think it's going to be very hard to enforce also, or, I mean, obviously there's no enforcement of it, of the rules anyway. I mean, you can walk around maskless pretty much in many, many states in the United States. But I think, yeah, once you're vaccinated, I mean, that's kind of the point. To avoid the rare possibilities, as you just described, of carrying COVID and giving it to your grandkids, or them giving it to you and you're getting sick. I mean, you know, this is where you have to do your own risk-benefit ratio analysis. And at this point, the risk category has gone down and the benefit has gone, well, the benefit's always been the same of seeing your grandkids, but maybe it's more beneficial because you haven't seen them in so long.
Exactly. There's
so another good question here, more research on long COVID. Yeah, there is more research. There was a study that came out, it was like 80-some thousand people with long COVID. And like something like 30% of them had cognitive issues, you know, mild, moderate to severe, like, you know, for weeks after COVID-19. We're also seeing, and I have a number of patients who've had COVID-19 who are experiencing ongoing malaise, fevers, low-grade fevers, and sort of brain fog and fatigue, if I didn't say that already. And you know what that is, we don't really know. What are your thoughts on that, Clay?
I apologize. I totally missed the question in your answer because I'm trying to scan through all the other questions to figure out the next one.
Fine. No, that's
long COVID.
Long COVID, like the data on COVID. I mean, we don't know why people are having this long tail of COVID and who is at higher risk. There's some correlation between the severity of illness and the severity of the cognitive deficits, which makes sense intuitively, but it's been borne out in studies. No. But we don't know why. Is it an immune overreactivity? Is it the antibodies crossing in the blood-brain barrier? We don't know. I haven't seen the
very, very latest on it, and I think it depends on the organ system that's involved, right? Certainly, there's a lot of worry about the inflammation and the virus potentially even getting into the brain through the nose. So the brain fog. I think there's gonna be some interesting things there. The malaise, I don't know, is that just the haywire immune system from it? I'm looking forward to seeing some of the data around the monoclonal antibody treatments and what that means from a reduction of risk of long COVID, frankly, of intervening early and giving the immune system some help with those additional antibodies. So
yeah, it stands to reason that would make a difference because, you know, giving monoclonal antibodies basically tamps down the virus's ability to reproduce or replicate in your body. So with less of a viral load, you would presumably have a less of a severe case, which is the point of the monoclonal antibodies, but presumably less of a chance of having long COVID, but we don't know that for sure because that has not been studied. Yeah. Any other good questions? I mean, there's so many good questions. It's hard to like navigate.
There's one, again, a very specific question about allergies to the vaccine. We touched on that a little bit. Again, the polyethylene glycol as an ingredient, I think they're honing in on that as a potential driver. Yeah. So again, if you have a history of anaphylaxis, carry your EpiPen. If you've got severe enough allergies that you have an allergist, I'm sure they're fielding tons of calls right now. There's no, like, all of the food allergies, not an issue. Most environmental allergies, not an issue. So now the CDC even came out and said, please don't pre-medicate with Benadryl. So that was interesting to see. I had advised a couple people to consider that if they were really worried, but then there was a concern it may be hiding some, you know, some people do have, if you have an anaphylactic reaction and you take that Benadryl prophylactically, you can actually delay that reaction, leave the medical system, feel like you're okay, and then have some of the problems down the road.
Yeah.
So it makes.
But again, like the broad picture here, the big picture is that really the vaccine is so safe. And if you have a peanut allergy, a penicillin allergy, a dog, pet, you know, grass allergy, like you are fine to get the vaccine. Yeah. Why are so many doctors telling patients to take melatonin? Beats me. I like the 2 O's and the so. It makes your point very clear. And I think melatonin is a great medication. If you've exhausted the normal ways we try to help people get sleep, like meditating before you go to bed, stretching, you know, minimizing your intake of caffeine and alcohol, you know, taking Twitter away from your face for at least an hour before you go to bed, having a bedtime ritual, you know, practicing mindfulness, then, you know, by all means take melatonin. It's pretty darn safe. And for some people, We think that it may have some antiviral effect in COVID-19, but it's not a panacea for sure.
Absolutely. No, I think it's that we are used to hearing about it as a sleep aid, right? And there is some innate immune system boosting potential antiviral effect of melatonin in like really basic science. There's no randomized control trial showing the benefit of it, but it is relatively safe, as you say. And you know, if you're sick, you're not sleeping well, you take a little melatonin, may get you some benefit, maybe on the COVID side. That's why I'm not going to, nit at the EVMS, recommending it. That's why I recommend it too. It's safe. It can help you sleep. Maybe it has some additional benefit. Hasn't been proven.
Real quick question to answer. Is it necessary to get the same dose for the dose 1 and 2, the Pfizer, Moderna? Yes. Why? Because that's the way it's been studied, and
Exactly.
we just, that's the way the studies have been designed, is to get the same vaccine. We don't want to mix them. We don't know what that would do. It would probably be okay, but we don't want to guess at this point. When we have this good of a vaccine and this good efficacy, you want to stick to the
protocol,
the plan A.
Yeah, I think it's safe. I mean, it's almost certainly safe, but it hasn't been proven either, right? There are not a lot of people who've mixed it up. I can't see why it wouldn't be, but stick with the data. Totally agree.
Yep. If you teach face-to-face and have kids with hives without any other symptoms, they come and go, any COVID relation, no. IMHO, there is no relation there. I could be wrong. What do you think, Dr. Ackerly? Kids with hives? Kids with hives, does that represent COVID?
Hives after COVID? Oh.
No, does that,
is that hives all the time? The fact that they have hives, do they have COVID?
Right.
Talk to your pediatrician. That is not something I'm aware of.
Right.
Yeah.
Yep. So people are asking about vitamin D, zinc. We answered that earlier in the little spiel, so maybe you want to rewind. Just recap: vitamin D, C, and zinc can't hurt you, and maybe could help. Best to get blood levels with your doctor, but they certainly cannot. They probably cannot hurt. So
there's a question about when, again, the repeats, do we need like a flu shot or tetanus? We talked about that a little bit earlier as well. I could see it sort of in between, possibly.
Yeah.
On the vitamin D, C, and zinc, again, I think, just be careful. You can overdose on D, you can overdose on zinc.
Yeah, you can. Yep. Why do doctors say after 10 days you can get out of quarantine? Well, so we just went over this. The epidemiological studies are very clear that people do not shed virus after 10 days. Is there one person in the world who does? Yeah, and people who've been intubated and are in ICUs, those patients are people who maybe need to be more careful, on recovery. But it's not arbitrary as to why we say 10 days. It's been well established that people don't shed virus after 10 days. What we do see, however, is that people will test positive on the PCR test for up to 90 days after they've been infected, which is distinctly not active infection. It's the viral remnants that show up on the very sensitive PCR test. So having a positive PCR test 2 weeks, 3 weeks after COVID-19 infection does not mean you're infected. It means you shouldn't have had the test, which is why we don't recommend a test after you've had COVID-19. We recommend
I think
10 days and you're done.
Yeah, for the people who are really nervous about it. And again, it's not quarantine, it's isolation. I know it sounds.
Oh yeah, I should have said isolation. Sorry.
Yeah. Of isolation. And there's a whole separate discussion of if you're quarantined, you've been exposed and you're waiting to see if you get sick.
Thank you.
When you be released, 14, 10, 7, there's active debate about that. Adding a test into that, when can you test? I do think that a 10-day with a negative test, pretty darn good, and you can release yourself from quarantine in most situations, unless you're about to do high-risk things with people who are high-risk individuals and you can't take those chances. But in terms of wanting to prove with a negative test to get out of isolation, A, that's not necessary. B, as you say, the PCR test can be positive for a long time. But for those who want something, I say seek out an antigen test. And those still can be positive, maybe, but a negative antigen test after day 10 is a reasonable thing to do, not necessary.
Yep. Yeah, I'm sorry if I confuse people. Isolation is when you are sick with COVID-19, you have a diagnosis, and it's 10 days, don't need a test afterwards, you're done. Quarantine, as Dr. Ackerly was just explaining, is when you've had an exposure. It used to be a full 14 days that we mandated, and it's still true that you can get COVID-19, or you can test positive for it 2 to 14 days after an exposure. But CDC has said you can leave quarantine after 10 days, with the knowledge that on day 11, 12, 13, 14, you could still develop symptoms. So yeah, it is confusing. But hopefully, right, once we have more people immune because of the vaccine, and we have herd immunity at some point, we won't need to be doing quarantines and isolations like we are now. I mean, that's the whole point of vaccination in the first place.
Yeah. Agreed. There's a tough question here to answer in terms of what percentage of people test positive and never have symptoms versus those who test positive and then have symptoms a few days later. I think the best data I've seen is for people who catch COVID, how did they get it? Did they get it from someone with symptoms? Did they get it from somebody who was truly asymptomatic and never developed it versus pre-symptomatic? And I mean, at least 50+% are pre-symptomatic or asymptomatic. And I think that is then split about 50-50 between truly asymptomatic individuals and pre-symptomatic. I know there's been some data back and forth on that. I think, I don't know if you've got other sort of factoids you want to toss out on that one. There are clearly a lot of people who remain asymptomatic and can spread it. I think several months ago, there was a big push to talk about those pre-symptomatic people, that a lot of it is being spread by people who are completely asymptomatic now, but will develop symptoms soon. I'm not sure what's behind the question, but certainly it's both.
Yeah. And we know that, I mean, maybe this is not answering the person's question, but we know that people can be, they're most contagious, remember, starting 48 hours before they develop symptoms up to 10 days after they're symptomatic. So, but it's probably in that, minus 24 hours to plus 48 hours that people are the most contagious.
Yeah.
And it stands to reason that people who have, severe COVID have more viral load in their nose and their respiratory tree, and those people are more likely to spread. However, we don't really know what makes people super spreaders.
Yeah.
It's not a compliment to be a super spreader, but someone, there are people who just spread it more readily. Maybe they talk more vigorously, or they project their voice more robustly. But it's an interesting question, actually, when you think about what is it, who's a person who spreads the virus more readily, and then these mutations or these strains of coronavirus that seem to be more transmissible. It's very hard to control for all these different variables, right? Like for a while, we were thinking that the UK variant was not in and of itself more transmissible. It's just that people in the UK who had that virus were just convening more, right? So like there's human behavior involved here too, and it's hard to tease out all those variables. Yet with genetic analysis, we now know that there actually is a more transmissible version of coronavirus circulating in various countries, including the US. And it's interesting to think about what is it that makes that particular version of the virus more transmissible. I think it's that the spike protein has a more affinity to like the little mucous membranes inside our nose, and that it can harbor there and breed more readily. But this is all this is the really, really, really intricate study of virologists and epidemiologists, and it's incredibly cool, I think, but we still have a lot to learn.
I mean, it's a very important variable for us to keep an eye on. The good news is the vaccines still work against it as far as we know. There is some potential concern about the monoclonal antibodies and what that might mean, but we need to keep a close eye on the variants for sure. But it's not something to panic over at all.
Yeah.
I think there's a great question that just came in. What do you do for patients who are in panic over all of this, legit panic attacks over this?
Okay, let's talk about it.
Great,
Fabulous
very, very important question. We spent, over 50 minutes now talking about all this stuff that can easily make you anxious. And I think in our early Facebook Lives, you talked a little bit more about this, and you sort of taken it for granted that we've been living in this realm of just constant stress and anxiety. And my short answer is you need to talk to somebody, right? Talk to your doctor, talk to a therapist. There's no easy answer here. It really depends on the individual. There are lots of different treatments for it. Just seek help, and you're not alone. I'm seeing this all over the place. And so, yes, we're now in 2021. The expectation that suddenly it was going to be a bright new day, that was not, a fair assessment. I was the December pessimist and March optimist. I'm still optimistic about where we're heading, over these next 2 months. But if you're feeling that anxiety, that panic, reach out to your doctor, reach out to a therapist.
I totally agree. I totally agree. And I've been talking about mental health as well for the duration of the pandemic, and even before that, because I do believe, as I know Clay, you agree, that mental health is foundational to our whole health. Yeah. And right now, we're in this state of like stacked traumas, right? Like we have experienced loss after loss after loss, from losing our routines to losing our ability to connect with other people, to, for some of us, losing loved ones to COVID-19 or for other reasons, and mourning the loss of lives over Zoom. So the first thing I say to patients who are feeling anxious is that that's normal. Like, we are wired for survival as human beings. When we experience a threat like a pandemic or changes to our lives, our bodies naturally they react, and we start pouring distress hormones into our veins and our arteries, and we get tense in our chest, and our heart rate increases, our blood pressure increases, we can get headaches, we can get migraines, we can get feel very ill physically and emotionally. So it's important to know that that's normal, but it also is true that just because it's sort of understandable doesn't mean you can't ask for help, as Clay was just saying. We can always grow the garden or increase the arsenal of tools we use to manage anxiety. And right now we really need more than just one tool at our fingertips. For a lot of people, they used to use going to the gym for stress management, or talking to their best friend every Saturday at yoga class, or, we now have to like diversify our portfolio of ways to mitigate stress. And, so exercise, prioritizing sleep, taking really, really good care of your body and mind by, turning off the news. Right now, we are living in a world where we see, so much news coming at us all the time. It's important to trim your media, prune your inputs, take breaks, take weeks off if you can. I mean, it's hard when we have this political upheaval going on right now. And then, as Dr. Ackerly just said, ask for help. If I teach my kids one thing, it's, asking for help is a strength. Reach out to the therapist, join an AA online. It's online. There are lots of free and wonderful support groups. SAMHSA has a good website. It's the Substance Abuse and Mental Health Services Association, where you can find local support groups and therapists, and just keeping the faith that we are going to get out of this. But in the meantime, it's important to not shelve your mental health, but rather address it like you would any other medical problem, as we were talking about earlier.
Yeah, so a line that sticks with me, and a line that I use with a lot of patients, is a line that I was given by my first attending in my first shift as an intern at Mass General Hospital, which was, never worry alone.
I love that.
And so it was my first night on call by myself with tons of patients, and he said, never worry alone. And if you're worried, call somebody. That's just as true for an intern scared he's going to kill every single patient on his ward.
Yeah.
To any worry you carry, right? You should not be carrying that alone. And we're flooded with worry. And so if you don't have someone you're sharing that with, it's worth finding that person.
And the last thing I'll say is that, we live in a world where misinformation is really an epidemic in and of itself. And unfortunately, we see lives lost because of misinformation. I mean, we all remember people who are drinking bleach. I mean, that's an extreme example of it, but it's important that you understand like who you can trust, where you can find facts, and then how to sort through all the noise, because there are a lot of we live in a world where you can be an expert on anything anytime. So Dr. Ackerly and I are not experts on everything. We don't know everything. Just ask my kids. But we do try to, in these Facebook Lives, help you sort through some of the noise. But I'm not saying just listen to us, but figure out like a few reliable sources, and then maybe just trim everything else away, because otherwise it can be very overwhelming hearing different opinions and different views. Of course, I welcome dialogue and opinion, and this is why we're here having these dialogues, but I think sometimes we can get overwhelmed with too many sources.
Absolutely.
All right, so I think we're done with the
That's
11th Q&A with Lucy and Clay. We'll be back in 3 weeks or so.
Yeah.
In the new month of February, and we'll do it again.
Look forward to it.
All right. Good night,
All right.
everybody. Thank you so much for joining us. Thanks for all of your great questions.
Absolutely. Thank you, everyone.
Okay.
Okay.
Bye.